now.
Programs of the East Zone, we started with case presentations and CPCs in a little deviation from what is happening all over the country. Uh, and in continuation of that, today's meeting is aptly titled "Back to the Bedside," and our chairperson today and would be Professor BP Chakraborty, who is Medical Director, Health City Hospital, Guwahati, former head of the Department of Medicine, Guwahati Medical College and Hospital, and former principal of various medical colleges. So I think over to Professor BP Chakraborty, and then we can start the proceedings. So we will have basically case presentations and ultimately concluding with a beautiful CPC, and hope everybody would enjoy. So without wasting any more time, um, Professor VP Chakraborty, please.
This gives me immense pleasure to present Dr. Bharat Panigrahi, MD FICP, President of East Zone Rheumatology Association, Senior Consultant in Medicine and Rheumatology in the Care Hospital and LBPEI, Bhubaneswar. So, Dr. Bharat Panigrahi will deliver his presidential speech.
Can I share my screen?
Yes.
Okay. So, thank you, Dr. Chakraborty, for your nice introduction. So, good evening to all friends. So, to start with, I must thank Dr. Pradeep for arranging this nice CME for EZRA. And as usual, now we have deviated from the previous CME. So this theme of the CME is like enough of theories, let us go back to bedside. So accordingly, to commensurate with this CME, I'll be presenting a case today. So my case is, it's a complete atrioventricular block in rheumatoid arthritis. This is a case report. So here is a male patient, at 63 years, who came to the emergency department of our hospital with complaints of one episode of syncope. So he was managed in the local hospital and subsequently referred to
full screen, sir.
Am I not audible?
It is not full screen.
Oh, I see. Okay. Is it okay?
Right.
Okay. So it's not a diabetes, neither a hypertension, but he has given history of polyarthritis 2 years, and he was on NSAIDs off and on locally. And on examination, patient was conscious, well oriented, but he was obese. Pulse was 53 per minute and regular. Blood pressure was on 50/70 millimeters mercury. SpO2 96% in room air. Heart sounds normal. No murmur. Chest was bilateral. Vesicular breath sounds. There is abdominal soft and non-tender. No hepatosplenomegaly. And central nervous system, there is no focal neurological deficit. Coming to the musculoskeletal examination, early morning stiffness was 30 minutes, more than 30 minutes. His tender joint count was 12/28 and swollen joint count was D/28. He didn't have any deformities of the joints. Investigations revealed that TLC was 11,500, hemoglobin 11.6 gram, and platelet count was 1.54 lakhs. ESR was 80 millimeters. His urea creatinine was within normal limits, and his liver function test again, ALT was little raised, STLT were little raised, and albumin was 3.5 within normal. PTINR and APTT were all within normal limits, and urine, it didn't have any abnormality. Thyroid function test was normal, and it is hepatitis B and hepatitis C were all negative, and HIV was negative. His rheumatoid factor was 114 AU, and antibody was it was 111 in unit. ECG, so ECG shows there's a complete atrioventricular block. So you can now see how there is a completely dissociation of this P and QRS, completely dissociation. So there is a complete AV block, the ECG showed. And echo, there is no regional wall muscle abnormality, no MR, and ejection fraction was 60%. And coronary angiogram was also done. It was a normal coronaries. And ultrasound of abdomen was normal, chest X-ray was normal, and also this X-ray of both hands that didn't reveal any erosion. So we diagnose it as a case of rheumatoid arthritis, is seropositive rheumatoid arthritis with high disease activity. DAS28 ESR was 6.3, and he had complete heart block. So he was treated with a permanent pacemaker. It is DR, that is dual chamber pacing, and he was given this conventional DMARDs plus low dose steroid. And patient was followed intermittently, and the disease activity came down. He was doing well with DMARDs and also this permanent pacemaker. So rheumatoid arthritis, this is all of us know, this is symmetric inflammatory polyarthritis of unknown etiology, and extraarticular manifestations involving skin, eye, lungs, heart, and others occurs in approximately 40% of the patients in RA over the course of the disease. Cardiac involvement coming to, it's again includes pericarditis, valvulitis, myocarditis, but AV block as such, it's very rare. In the literature, there are only case reports. There is only one case report, and in literature, there are only a case series of 8 cases were there, but otherwise only single case reports are being represented. So it's very rare, and usually, and AV block is usually complete and doesn't respond to anti-inflammatory and immunosuppressive therapies. So the approximate incidence is almost as reported Aaron et al. There is 1 in 1,000 patients of RA, and the other one, this Rascaron was found. They have also found that incidence is 1 in 1,600 patients of RA. The postulated mechanism of pathophysiology, this primary infiltration of the AV node or other conducting tissue by mononuclear cells or rheumatoid granulomas, vasculitis of the arterial supply to conductive tissue, extension of the inflammatory process from the base of the aorta or mitral valves to the conduction pathways, amyloidosis, and hemorrhage into the rheumatoid nodule. So usually, AV blockage detected in long-standing erosive and high disease activity RA, as published in literature case reports. And in our case, the duration of polyarthritis was only 2 years, non-erosive, and the patient presented with a complete heart block before he was diagnosed as a case of RA. Thank you.
As no questions are allowed in this presidential address, we may go to the next.
Thank you, sir. It was a brilliant presentation. Now, I have been designated with the task of introducing three celebrities, stalwarts of rheumatology onto this forum. They are Professor Alakindu Ghosh, sir, Dr. Vidut Das, and Professor R.N. Mishra, sir. Sir, I'm saying your name at the end, not because we don't respect you the highest, it's because perhaps you are the most star-studded person in this panel. Sir needs very little introduction to this August gathering, but just to touch up a little, I hope I don't hurt you by missing something important. He is presently working as professor and head of the Department of Clinical Immunology and Rheumatology and Dean of Research and Development at the Kalinga Institute of Medical Sciences, Bhubaneswar. As we know, he is the person who has built up the Department of Rheumatology and Clinical Immunology at SGPGI, Lucknow, from where he retired in the year 2019. And he has given a brilliant career to a lot of students groomed under him. He has got a lot of publications to his credit. He has a lot of laurels, and I don't think it needs any reputation to this August gathering, who knows much more than I do. Sir, I hope I have not said anything less for what you could have expected on your introduction today. Next, I shall be introducing Professor Alakindu Ghosh, sir, who is the president of IRA and the head of the Department of Rheumatology at the Institute of Postgraduate Medical and Education Research, Kolkata. Sir is definitely a brilliant star of rheumatology of this whole northeastern region. He has been our torchbearer for long, and now being the president, we all look up at him. Then here is Professor Vidut Das, who is a brilliant teacher. We've learned a lot from him. Needs very little introduction to this gathering. Anyway, once again, to tell you, he is the head of the Department of Rheumatology at SCB Medical College, Cuttack. He is the adjunct faculty, Institute of Life Science, Infectious Disease Biology, Bhubaneswar. He has got many awards and publications to his credit. Having introduced these three star-studded persons who will be carrying us through this CME, I now invite Dr. Sakir Ahmed, who is Assistant Professor, Clinical Immunology and Rheumatology at KIMS University, Bhubaneswar, Assistant Editor of the Indian Journal of Rheumatology, and who is also onto various editorial boards of many prestigious journals. Now, he shall be talking to us about Jack and KU climbing up the hill. You have 20 minutes for your presentation, sir.
Sakir, you have to unmute yourself first. And Sakir, you are not audible. Sakir, you are muted. You have to unmute. Sakir.
You probably have to give him a call.
Yeah.
Hello.
Yeah. Now you are muted.
Yeah. Sorry for the interruption. As I was wishing good evening to all the respected dignitaries and the delegates for today's meeting, and I would thank the organizers for this opportunity to present. As ma'am had mentioned, what I'm going to present is Jack and Ku climbing up the hill. So here we can see the present President of the United States. he's trying to climb up a hill. What is the significance of that is that climbing upwards requires the active participation of the proximal muscles. And if there is difficulty, we usually think of a proximal myopathy. And why Jack and Koo, that we'll see as the case goes by. So the theme for the meeting was, let's go back to the bedside. So I'll not keep this as a formal case presentation. I'll present it more as a story. So this was a female patient who was 28 years when she first came to us in 2017 at HGPGI. She had come with skin thickening for 1 year, some fatigue and heartburn. But what was more interesting was that her mother used to carry a pistol in her purse. And initially they were seen at one place in Assam, and the mother had registered a FIR against the doctors. So what the doctors did there, they referred the patient to HGPGI, also gave my phone number that you go and meet him. And since then, I have been taking care of this possibly dangerous patient. So when she came to HGPGI, that was in March 2017, we discovered that she had patchy scleroderma. There were affected areas of skin which was not continuous like classical scleroderma. And atypical for scleroderma, she also had a malar rash. And there were significant contractures above the shoulder and hip joints, which caused her some difficulty in wearing clothes. And she had proximal muscle weakness, and myositis was confirmed with raised muscle enzymes, though we did not go for a muscle biopsy. Initially, she was started on methotrexate, but we could not increase the dose beyond 15 milligram because she had GI upset. Another problem, as I said, was heartburn, and she used to suffer from gastrointestinal reflux. Initially, prednisolone was started at 20 mg because scleroderma overlap was there. We were afraid of giving a higher dose, and there was a partial response. But as soon as we tried to taper down the steroid, again she had proximal weakness as well as a return of the skin. This was the rash she had. It was not a classical malar rash of lupus, but more of a erythematous rash occurring all over the body, but more prominent over the cheeks. And first relapse, her MMT8 was 54. Then other major issue was the gastroesophageal reflux. Upper GI endoscopy was done, which was normal. Initially, she was given option for rituximab, but she was hesitant, and we added leflunomide to methotrexate. The leflunomide was well tolerated, but she did not have any. The steroid sparing effect was not there. As soon as we reduced the steroid from 15 to 12.5, the rash reappeared. We wanted to look for refractory myositis, and at that time we looked at the myositis specific antibodies, and we found that she was positive for NT-Ku. And that time I had also come over to Bhubaneswar. At the end of 2018, I joined at KIMS Bhubaneswar, and she followed me here. And since she had not responded to leflunomide, we gave her rituximab. She got 1 gram 14 days apart, and methotrexate was now increased to 20 milligram. We thought we'll try to maintain her on methotrexate and maybe repeat rituximab after 6 months. Again, she had some response. Steroid could be brought down to 10, but again, within 4 to 5 months, she again started deteriorating. The weakness increased, and she again had the rash. And also, we can see in the photo, she is also developing Cushingoid features because she has been on steroids for such a long time. And that time she also had multiple episodes of possible syncope. And because anti-Ku syndrome is associated with cardiac involvement, we screened her with Holter, and other echo and routine tests were also done. But we could not find any cause for the syncope at that time. And but a major issue at that time was her anxiety. Her family was worried about her image and her marriage, and she was also worried about her body image because she was gaining so much of weight. So ultimately, we added some SNRI, with which she was improved. And because of the heartburn, she also got an ultrasound done which showed cholecystitis. And in the last part of 2019, she got admitted once again for a cholecystectomy. Then, because her muscle weakness was still there, we decided to shift her to tacrolimus. She started tacrolimus, but she could not come back for follow-up. And over teleconsultation, we looked at the tacrolimus level and maintained the dose of, titrated the dose of tacrolimus. But despite tacrolimus, whenever we reduce steroid below 15, she would have that muscle weakness and flare. And patient was getting quite distressed because she was not able to reduce her steroids. So what do we do next? Ultimately, we decided to go ahead with tofacitinib. We started at a dose of 5 milligram twice daily, and methotrexate was continued in the background. This was after 1 month of follow-up. Her weakness was better. The rash had improved. At that time, we also looked at her thyroid profile because it was almost 1 year since it was repeated. And we found that T3 and T4 were low, but TSH was normal. This was consistent with central hypothyroidism. We also looked at luteinizing hormone and follicular stimulating hormone because those can also be associated with central hypothyroidism. And in consultation with endocrinology, we started her on thyroxine. At 3 months, her steroid we have gradually reduced to 7.5. Now she has completed 4 months on tofacitinib, and she is doing well, and she is being planned to have a marriage next year. She already had her engagement 2 days ago. I think on the 10th of December, she informed me that she was having her engagement. So coming to the discussion, anti-Coup syndrome is basically first described in 1981 in patients having scleroderma and polymyositis overlap, which was classical in our case. This is basically a DNA binding protein, and it can be found in approximately 1 in 650 to 1 in 3,500 ANA positive serum. 34 patients who had this positive, out of them, in this case series out of 34, 11 had predominant myositis, and out of that 11, at least 8 had overlap. 5 with systemic sclerosis, 2 with Sjogren syndrome, and 1 with lupus. And other patients, 19 of them, they had other autoimmune diseases without myositis, 6 lupus and others as shown. And the remaining, I think, 4 patients out of that 34, 4 patients did not have any symptoms or did not meet criteria for any autoimmune disease. Looking at the U-star cohort is the collection of all the systemic sclerosis patients in Europe, and they looked at the serum of total 625 patients, and out of that 625, 14 patients were anti-Coup positive. They have not provided details in this paper, which was way back in 2008. This is another paper which looked at different patients with anti-Coup. They had a total of around 42 patients. And out of that 42 patients, they could group the patients into 3 categories. What was seen, arthralgia was common in all of them. One group had predominantly myositis, muscle weakness with raised CPK. One group had predominantly renal involvement, glomerulonephritis. And one group did not seem to have either of this. And what was also interesting was that patients with myositis usually have a lot of ILD, and this ILD is responsible for death. So there are case reports that anti-Coup syndrome is associated with myocardial involvement. It is associated with hypothyroid myopathy, which was there in our patient, and the prognosis depends on absence or presence of interstitial lung disease. Coming to the second part, what do we mean by resistant myositis? There is no definition till now. So what has been suggested is that if on tapering the steroids below 10 mg, despite at least 2 steroid sparing agents, suggested the first line and second line are usually methotrexate and azathioprine. If these two are not, despite these two, the steroid cannot be brought down below 10, this can be called resistant myositis. If we look at the literature, the drugs suggested for refractory myositis are rituximab, IVIG, which is very costly for maintenance every month, then cyclosporin or tacrolimus, and JAK inhibitors. Of this, we have tried rituximab as well as tacrolimus, and ultimately we succeeded with JAK inhibitors. So what are JAK inhibitors? JAK, initially when it was discovered, it was called just another kinase. Later on, the name was changed to Janus kinase. Here we can see this is Janus. Janus is a Greek god. He's talking here with Mercury, another Greek god. and he's known for having two faces. So he's the god of portals. He'll look on both sides of a doorway or a portal. And whenever a cytokine comes and attaches to a cytokine receptor, if the JAK is present downstream, this JAK causes phosphorylation of the stat. And two stats, once they are phosphorylated, they dimerize and go directly to the nucleus. There is no third messenger involved. Since it goes directly, that is also one reason why it is called stat, though the full form is something longer. There are different JAK inhibitors which have different effects. Some are predominantly JAK2, and these are mostly used for hematopoietic malignancies. And some which are against JAK1, they can be useful in case of arthritis and diseases such as myositis or lupus, where there is an increased interferon signature. And just this month, this was published in the 1st of December. This is the largest case series of tofacitinib in refractory myositis. This was published in Arthritis and Rheumatology, where they had 10 persons, and the primary outcome measure was the IMAX score, which is a standard for myositis, and at least 50% of refractory myositis had moderate improvement as defined by the IMAX, and the other had some minimal improvement while on tofacitinib. So to conclude, anti-Coup syndrome is a overlap myositis, usually with lupus or systemic sclerosis, or Sjogren. ILD is common, especially if the patient has associated systemic sclerosis. It can have myocardial involvement as well as hypothyroidism. And for refractive myositis, there is no fixed definition yet. The drugs available are rituximab, tacrolimus, and all the emerging JAK inhibitors. So the story is still gone. Picture abhi bhi baki hai. Till now, I'm safe from the gun, but I think there is still a long way to go. The girl has just got married. Tomorrow, if she wants to get pregnant, she's on tofacitinib as well as methotrexate, which are both contraindicated in pregnancy. Then I don't know what is going to happen. Thank you.
Sakir, it was a nice presentation and really a very exciting new concepts. But I think as because it's more of a clinical exercise, do you provide the algorithm when a patient presents to us with a proximal weakness, after excluding the standard rationally, we put forward as a diagnosis of idiopathic inflammatory myositis and dermatomyositis predominant. From that point up to Coup syndrome, how do you progress with the patient? So that will be more informative and helpful for the clinician. Your working diagnosis in these patients?
Initially, the working diagnosis was a systemic sclerosis polymyositis overlap, because she did not have all the classical features of dermatomyositis except for the malariash, and the malariash has been described by in polymyositis. So the working definition was always limited systemic sclerosis with polymyositis. And when it was resistant, that is why we wanted to look at what antibodies are there to look at the prognosis if there was a possibility of necrotizing myositis. And that is when we discovered the anti-Coup syndrome. It is not recommended to do the myositis specific antibodies first go. This can be done as a part of a academic or research program, but usually the presence or absence of antibodies do not help to make a diagnosis or in the management. However, in such cases where there is refractory, then we may go ahead with it.
All right.
Thank you.
I don't see any questions.
May I share one experience of one patient, Sakir? I'm Dr. Dhrubajyoti from Guwahati. Actually, 6 months back, one patient of 28 years admitted in pulmonary medicine ward with ILD. And that patient for last 4 years has been suffering from severe muscular weakness, scleroderma like fissures, sclerodactyly, and Raynaud phenomena. So initially diagnosis was made MCTD, mixed connective tissue disease, on the basis of 2+U1 RNP. Then patient was treated with disease modifying agents, then no response to those medications. Then ultimately the ILD was severe, progressed to a severe form, and admitted in pulmonary medicine ward. Then the consultant requested me do something, maybe something else. So then we have checked that NTQ was 3+, it is positive. And I think on literature search, the Raynaud phenomena is also there in NTQ positive patients. Severe muscle weakness, scleroderma, almost pictured clinically is like MCTD in NTQ patients. So we have started the patient on IVIG and MMF, and there was dramatic improvement. And now 6-month follow-up, patient is well without any pulmonary symptoms, without Raynaud phenomena, without muscle weakness, and scleroderma has been resolving.
Thank you, sir, for the insight. My patient also had sclerodactyly and Raynaud was there. That was managed by PD5 inhibitor. And regarding MCTD, the experts are there, they can give their opinion. But once the patient develops scleroderma, there is skin thickening, and fulfills criteria of systemic sclerosis, we cannot make a diagnosis of MCTD. Then maybe we call it a overlap syndrome, but diagnosis of MCD means it cannot fulfill criteria for either lupus or systemic sclerosis.
Sakir, I have one question.
Sir.
You never did an ANA, I suppose. You went to the ANA profile. Were you skipping the routine procedures? Patient?
So ANA was done. That was done. Usually we do not do ANA in case of systemic sclerosis. Systemic sclerosis is self-evident. But for this patient, ANA was done. It was positive. I think homogeneous pattern 3+ or 4+. That was done when she had first come to a GPGA.
How did you explain the homogeneous pattern?
Sir?
You explain the homogeneous pattern.
Exactly, I am not able to explain it, but most of the systemic sclerosis patients we are seeing it is homogeneous pattern. Usually, when the SSS is there, maybe we can expect.
It's fine speckled. Normally, it is fine speckled. You can get, but the other thing is, the patient, you said IVIG was very costly. The patient could afford rituximab and Zelzang and all that. Do you think he could have taken IVIG?
But IVIG would be monthly. The cost of rituximab is around, that was maybe 30,000. 30,000 single go. But IVIG will be high cost every month. And even Gens is available around 16,000 per month.
No, when we had started, is IVIG to be given every month if he responds with one course along with methotrexate or azatha, whatever you gave? I don't think we could have gone to rituximab or could have gone. But why didn't we try that as one option before you went to tofacitinib?
If you look at the evidence, the IVIG, there is a recent paper even published in IGR. I think Gangaram has used a lot of IVIG for myositis, and they have not had very good success. So looking at the literature, I was not very much convinced that IVIG would help her. However, the JAK inhibitor is an emerging drug, and there are plenty of cases, even in refractory MDF5 ILD, that JAK inhibitors have a good role.
Fine. So I think that's really a very exciting presentation. We can move to, if there is no other comments or questions. Chat box also not showing any questions.
Chat box shows no questions. No questions.
Dr. Mishra to comments anything, or you can move to the next case.
So you have to unmute yourself.
Two autoantibody system within the myositis antigen extended profile are associated with overlaps. One is PMSCL and one is Q. Generally, I thought of whatever cases I've seen, they are generally milder variety of scleroderma with RA or scleroderma with myositis overlap, and not requiring the drugs that we are talking about. Usually they have limited systemic sclerosis and myositis which is well managed with prednisolone at a very small dose. This case is interesting that in the sense that the severity of muscle disease necessitating drugs like rituximab and tofacitinib, this is odd for anti-Q antibodies. Generally, anti-Q antibody and anti-PMSCL, if there is progressive ILD, if the ILD is progressive, that would require. Sometimes I feel the gun might have forced Sakir to
overreact,
to give the drug, but I haven't seen such a case where you are pushed to the corner to try drugs like rituximab and tofacitinib. But then I left it to the clinical decision of I'm still worried about the new drugs, the JAK kinase inhibitors. What about their unexplored side effects, and we still don't know enough of it. We know what the limited exposure in rheumatoid and psoriatic arthritis is. Sometimes drug effects are because of underlying disease also. Means in certain disease you tend to see more disease, and in we know in certain HLA types are associated with certain disease. So, well, it is interesting that antibody to Q can be associated with a clinician forcing to give drugs like tofacitinib and rituximab. But anyway, there can be exception. I've seen patients with antibody to PMSCL having progressive lung disease. So we learn every day.
In your experience, anti-Q in your experience with
all anti-Q that I have seen are actually patients with rheumatoid arthritis with some features of scleroderma.
Right.
And sometimes myositis patients can have localized scleroderma, means they have patchy skin changes, not like a scleroderma distribution, but they have patchy changes of the skin. It is said that nail fold capillary microscope can sometimes helpful in differentiate that. But I pray God that the gun is never used.
Thank you, sir. I think now
these cases also associated with anti-K associated with thrombocytopenia. Usually that we do not see in patients with this dermatomyositis, myositis. That thrombocytopenia association we get in patients with anti-K antibody positive.
Thanks.
So,
nice presentation, Sakir. Great thanks to you. Very new information. Challenging. Good. Let's hope for the best. Let's move to the next case. Yeah, I think.
Yeah, the next on our agenda is a presentation by Dr. DJ Sharma from Assam. He's got 20 minutes for his presentation, Kinetics of a Child with Polyarthritis. Rubajyoti Sharma, as we all know, he is DM, Clinical Immunology and Rheumatology, and he is presently holding a post of Assistant Professor Pediatrics at the Guwahati Medical College. He is also a consultant at Medicity Hospital in Guwahati. He's got numerous publications to his credit, a brilliant student. And let's see him get going. You have 20 minutes for your presentation, including the discussions.
Thank you, madam. And thank you, teachers and chairpersons and the dignitaries today. So this is a 7.5-year boy from Sualkuchi, Assam. So this Sualkuchi is famous for our muga. So this child was symptomatic since 4 years of age with pain and swelling of the bilateral knee joints, ankle joints, wrist joints, and proximal interphalangeal joints of right index, middle, and ring fingers. So the presentation he had was typical of a case of polyarticular juvenile idiopathic arthritis. Here in the picture, you can see there is swelling of proximal interphalangeal joints, and there is deformity at the knee joints, flexion deformity. So the course of arthritis before referral to us was 3.5 years. During that period, the child sought consultation from several physicians, and he was treated with methotrexate, leflunomide, sulfasalazine, SCG. These are a disease-modifying agent was used for treating this child, and also used was intermittent short courses of oral prednisolone. But there was no significant response, and ultimately the arthritis was progressed, and there was development of flexion deformities of the bilateral knee joints. So after that, child was referred to us. The referral diagnosis was juvenile idiopathic arthritis. So child came to our clinic. At that time he was limping, and on reviewing the clinical history, he had acute suppurative otitis media at the age of 2 years. There was 2 episodes, and he had pneumonia requiring prolonged hospitalization and prolonged intravenous antimicrobials. There was 2 episodes of severe pneumonia, 3 episodes, 1 at 4 years of age, 2 at 3 years of age. He also had pyogenic meningitis at the age of 4 years. For that, he was hospitalized for 3 months. And at the same time, he developed arthritis involving the joints, as I have already mentioned, one by one over a time. Then the arthritis was persistent till the time of referral. Then I got the child at 7.5 years. On the family history revealed the child was the second child of parents of non-consanguineous marriage. No history of death of any family members at early age. There was no history of serious illness in any of the family members. On clinical examination, he was not thriving well. The weight was less than 3G score, height was less than 3G score. He had absent lymph nodes and tonsils. We did not get any palpable lymph nodes, and tonsils were absent at the tonsillar fossa. This is the height of the lymphoid growth in a child, but we are not getting the tonsils. He had swollen PI proximal interphalangeal joints of right index and ring fingers. He had restriction of movements with flexion deformity at the left wrist joint and bilateral knee joints. Systematic examination findings were unremarkable. So we had the diagnosis of polyarticular juvenile idiopathic arthritis in the context of immunodeficiency. This I have thought because he had several severe infections in the past. Initial investigation was apparently normal. There was mild thrombocytosis. EZRA was essentially normal. On X-ray examination, radiologist had reported as erosion at the epiphysis of the right femur. On immunological investigations, he had pan-hypogammaglobulinemia. All classes of immunoglobulin were reduced. And on flow cytometry, the CD19 B cells were absent. So if you get in a child with recurrent infections with absence of tonsils and no palpable lymph nodes, with that picture, we get this type of immunological investigation report. Then we have the diagnosis of X-linked agammaglobulinemia. On exon sequencing, he had large deletion of 2757 bases extended from intron 7 to intron 9. Here, this is the control. Again, exon 8 is there, exon 9 is there, that is absent in both exon 8 and exon 9. In the index patient, both were absent. On sequencing, there was discovery of a novel mutation. This was not previously published. So with all this, we got a diagnosis of X-linked A-gamma globulinemia. So why we have suspected a primary immunodeficiency in this child? So as per the, in a brief, I want to say, as per the Jeffrey Model Foundation, that developed 10 warning signs to suspect immunodeficiency. In immunodeficiency, children or any patient can present to a ENT physician with 8 or more new ear infection within 1 year, 2 or more serious sinus infections within 1 year, 2 or more months on antibiotic with little effect to a physician, or pulmonary medicine with 2 or more pneumonias within 1 year, or failure of an infant to gain weight or grow normally. Then patient can have recurrent deep skin or organ abscesses, persistent pus in mouth or elsewhere on the skin after is 1, need of intravenous antibiotics to clear infections, 2 or more deep-seated infections, and a family history of primary immunodeficiency. If 2 or more of these warning signs are present, then we should suspect primary immunodeficiency and we should go for investigations. This is in a nutshell a slide of the classification of the immune system and the response. The broadly classified as innate and adaptive. Innate is comprised of macrophage, neutrophil, phagocyte, antigen-presenting cells, and adaptive immunity by B lymphocyte and T lymphocytes. And when antigen-presenting cells come in the context of antigen, if they cannot encounter that give to the T cells, then T cells are divided into helper T cells, 2Th1, Th2, and several other types according to the antigen type. And there can be cell-mediated immune response or humoral immunity. So in patients with this phagocytic defect and T cell immune deficiency, they usually present earlier in life with recurrent viral infections or infections by unusual organisms or TRAS and failure to thrive. But because of the persistence of maternal, passively transferred maternal antibodies to the child, fetus, these children with humoral deficiency or immunoglobulin deficiency, they usually do not manifest before 6 to 9 months of age. So once the antibodies start winning, then only they become clinically manifested. So the basic defect in the hypogammaglobulinemia is there are 2 types. One is X-linked gammaglobulinemia and other one is common variable immunodeficiency. These are the common types of hypogammaglobulinemia. Here in XLA, the stem cells are developed up to pro-B cell stage. There is a mutation in the Bruton tyrosine kinase gene. Because of that, this protein, Bruton tyrosine kinase, that is required for expansion and maturation of the B cells from pre-B to pro-B and mature B cells. Because of the mutation, the mature B cells are not developed. That is why there is the reduce or absence of the B cells. On the other hand, in CVID, these mature B cells are well formed, so B cells are normal in number. However, there is a defect in the transformation of these mature B cells to antibody secreting plasma cells. So in suspected humoral defect, we go for immunoglobulin profile. There is hypogammaglobulinemia. Then if there is absence of reduced number of B cells, we suspect X-linked gammaglobulinemia. Or there is presence of normal numbers of B cells, then we suspect common variable immunodeficiency. In X-linked gammaglobulinemia, there are repeated episodes of pneumonia, repeated episodes of ear distress, recurrent or chronic diarrhea, near total absence of B cells, and hypogammaglobulinemia, and clinically we get absence or atretic tonsil with no palpable lymph nodes. The infections we get in these type of patients are infection, respiratory infection, maybe upper respiratory infection like otitis media, sinusitis, or lower respiratory infections like pneumonia. This is caused by Staphylococcus aureus, like pneumococcus, meningococcus, and Haemophilus influenzae. And mycoplasma that is encountered, that usually causes arthritis in these children, and echovirus, meningoencephalitis, and myositis, this dermatomyositis. So the arthritis in XLA, usually monoarticular or oligoarticular, and knee joint is most commonly affected, and most common organism is the mycoplasma. Other type of arthritis is septic arthritis caused by Staphylococcus. Klebsiella is also detected in certain number of patients, and also capsulated organisms like pneumococcus and Haemophilus influenzae. And the arthritis can be like this index side due to immune dysregulation, and presentation can be like JIA, like in this child. So there are only case reports which are available on arthritis in patients of X-linked agammaglobulinemia. Only these case series I have found from conference abstracts. This is not a published case series from a tertiary care hospital of India, North India. Total patients 62 with X-linked agammaglobulinemia. There were 17 cases of arthritis. Arthritis preceded the diagnosis of X-linked agammaglobulinemia by 2 patients. 2 patients the arthritis detected earlier than the diagnosis of XLA. And arthritis was initial patient in 5 patients, and arthritis developed after the diagnosis of XLA in 10 patients. Arthritis was most common, with knee joint involvement was the most common presentation. Septic arthritis in 3, and arthritis involving proximal interphalangeal joint in 1, and sacroiliitis in 1 patient. So polyarticular JIA has been reported only in 5 patients so far in the literature. Out of these 5 patients, only 1 patient had detection of Klebsiella pneumonia in the culture of synovial biopsy specimen. So we treated this index site with regular replacement IVIG at a dose of 400 milligram per kg and continued monthly. Interestingly, we are very happy that intravenous immunoglobulin is supplied free of cost at our hospital. We are taking this opportunity in managing these children. And also we have started with cotrimoxazole prophylaxis, and naproxen we prescribed for initial 4 weeks. Child had dramatic improvement. Now he is class 7, a student of class 7 standard. This is the child. That photograph was taken yesterday. 13 years child now, on regular replacement IVIG and cotrimoxazole, no new infection, no recurrent infection, and no recurrence of arthritis. It was so dramatically improved. And now child looks healthy with age appropriate weight and height. And thank you very much for your kind hearing. I want thankful to the Allergy Immunology Unit of Advanced Pediatric Center of PGIMS Chandigarh for carrying out this immunological genetic test. Thank you very much.
Thank you, Dhruba, for your brilliant presentation. We are open to any questions from the experts, or we don't have any questions from the audience. Sir.
I have a question to Dhruba. Excellent. We are missing actually. We don't do this immunoglobulin tests routinely in our center here in Pediatrics Institute. So most likely we are missing a lot of these cases. The bottom line is, when you get such a case, isn't CVID you get more arthritis in CVID rather than X-linked agammaglobulinemia?
Yes, sir. Because
you look at the prevalence.
CVID, the age of onset is usually, yes, sir. So CVID is much more common than.
The prevalence of arthritis and autoimmune manifestations are a little more, I think, common in CVID than in X-linked agammaglobulinemia. I'm not sure. I don't have the literature about
Exactly, sir. Because CVID is most common in humoral immune deficiency, but this is usually present at later life. Most we have adult patient with CVID, and only 1 patient of 20, age 20. Others are age 45, 30. So I have 4 patients with CVID, all are adults. But XLA we get in children, but CVID in a later life.
What is the prevalence, or what is the incidence of CVID in children below 14 years?
Sir, we do not have any prevalence data, but as a whole worldwide, 1 in 50,000 worldwide data. And actually selective IgA deficiency is much more common, 1 in 300 and 400.
IgA deficiency.
Yes, selective IgA deficiency. It is
And
much
you
more
don't,
common.
these arthritis, they don't require DMARDs for their management?
Usually people are treating initially, but after the diagnosis of XLA, everybody has switched over to IVIG regular. Then with that, all arthritis have been resolved. I think
This
IVIG
IVI
has a
need to be
dramatic role.
continued lifelong though. This
Yes,
IVI
sir.
need to be continued lifelong.
Yes, sir.
Yeah.
Yes, sir. Lifelong. No other way.
No other way.
Monthly? Is it monthly?
It is usually 3 to 4 weekly. So we prefer to give 4 weekly. 400 to 800 milligram per kg.
Monthly, yeah.
4 weekly.
We have patient and they are being continued monthly, and it's a very difficult task. Yeah.
Yeah, so, but we get IVIG free of cost. We are taking, but I don't know how long they are continuing free of cost.
In our place also, till now it's free of cost, but it's becoming difficult. Yeah.
Yes, yes, sir.
Pradipto, yeah, Pradipto. Yeah. Pradipto.
Yes. Yeah, Dhrubajyoti, a very good presentation. From what I point out this case is, if the patient of polyarticular GI is not responding to the number of DMARDs, then we should think of such type of association. Second is,
exactly.
Some point odd is why the lymphocyte count is not low. This patient, when you did that lymphocyte count, total TLC count of 13,000 and neutrophil 65, lymphocyte 26. Normally, agglomeralulobulinemia or CVID, the lymphopenia should be there. But I cannot explain why the lymphopenia is not there from this case. So what is the albumin globulin ratio? In every case of CVID, you see the hypoglobulinemia and lymphopenia. But in this case, I am not getting any lymphopenia in this case. Can you explain, Dhrubajyoti?
Yes, actually, no, I think T cells take major part in lymphocyte count. So I think that is not reflected in the DLC. And I don't know why this albumin globulin is not. Albumin is normally higher than globulin. That picture we get. But I don't know some percentage beyond which we can take it is, yeah, clinically globulin is too much reduced than albumin. Then we can, I don't know. I have no any such data.
Yeah, thank you.
Yes, Olgo, yeah. Olgo is there.
Yeah, regarding Dr. Pradipto's questions, probably if we get a low lymphocyte, then we should think of a combined deficiency than pure B cell. Like CVID or XL is a CVID, if you're talking about, it's more of a functional defect. So we don't get usually B cell low. This is a very rare variant of B negative CVID. So it's a relatively newer concept. So B negative CVID is a relatively new thing. And so usually
Kids at home.
So we usually don't get lymphocyte low in case of CVID. And rather than looking for non-responding to what we more miss the history of infection. We don't usually take infection history in most of the cases. That we miss more. I feel what I have experienced during my training.
I think two things are very important for everybody might agree are recurrent infections. As you told, pneumonia, CSOM, etc. in a child, recurrent is something, and unusual infection, unusual sites. These are three things where you have to keep your antenna up and think about primary immunodeficiency. Professor Mishra has anything to say?
There are certain oddities about this patient. The polyarticular GIA rarely is ever a manifestation of X-linked gamma globulinemia, because the primary, the autoimmune feature though is present in about a quarter of patients with X-linked gamma globulinemia, primarily take a presentation of colitis and other autoimmune features, not of polyarthritis. You can get, as he said, oligoarthritis or single joint arthritis. That is primarily because of bacterial infection, or you can get also fungal or tubercular infection. To have a polyarthritis, JIA polyarticular type, is very odd. And that too, a deforming knee joint arthritis with a ESR of 5. That is, I can't understand. And I mean, he's brilliant enough to make a diagnosis. But if you look at the child infection, the definition of a recurrent infection is you have to have 3 infections per year. But this child had 1 infection per year over several years. I don't remember that graph very correctly. No doubt there were different site infection, but the diagnosis was clinched by the B cell deficiency. We don't know what his T cell studies are, nor his NK cell studies are. And Pradipta's question why there was no lymphocytopenia, with Dhruva answered correctly. 80% of the peripheral blood lymphocytes are T cells, and only 16 to 20% are B cell. So a B cell lymphopenia, a B cell depletion would not reflect so much. But I'm still intrigued by the polyarticular deforming arthritis like JIA in the case of X-linked gamma globulinemia. But if his arthritis has been corrected by IVIG, I just want to understand what was the pathology behind the polyarticular nature. The autoimmune manifestation of X-linked globulinemia is not like a polyarticular JIA.
I agree, sir. Actually, the diagnosis cleansed by the manifestation and recurrent infection and absence peripheral lymph nodes and tonsils. These are very telltale, important telltale signs of suspecting X-linked gamma globulinemia in a boy. Usually diagnosis. And polyarthritis has been reported only in 5 milliliters, sir. This is the 6th, sir. So the immune dysregulation is the mechanism that has been postulated. And in arthritis, mycoplasma is most commonly encountered, and people have treated for that. But problem is that we cannot able to diagnose mycoplasma arthritis in our setting because the PCR, these are very high quality PCR is needed, as well as the culture, special culture is needed. These are not available commonly in our country. So we have people have not done the workups for mycoplasma so far, but some given empirical azithromycin for these patients. But our patient has responded well to IVIG, dramatic response. So I think it is confirming the diagnosis, the etiology.
Before Madam, you continue, I just an announcement. I request all the audiences to put their questions in the chat box, because we are seeing that there is no questions. It will be actually more, we feel better if there is some questions. So I request all the audiences to put some questions in the chat box. That is one. And number two, Ologendo sir was worried that we have only 19 participants. So this window is only for the faculties. Now we have more than 100 participants till now. Yeah. So please, Madam, you can continue.
Thank you, Dhruva. You have really stirred a lot of questions into us, and we've learned a lot in the course of your presentation. The next speaker is Dr. Argha Chattopadhyay, who is also a MD-DM, RMO and clinical tutor at the Institute of Postgraduate Medical Education and Research, Kolkata. His presentation has been entitled as Another Interesting Patient, and you are allotted 20 minutes, including the discussion.
Aditya. Madhumita madam, can I put in a little suggestion? Can you ask the audience to type their questions into the chat box?
Yes, Pradeep just put in a word. Audience, you are free to type questions into the chat box. That makes the sessions more interactive and more interesting, I think.
Yeah.
Thank you, Madam, for your kind introduction, and thank you, the EZRA, for giving me the opportunity to present the case. Is my screen is visible?
Yes.
So this case is also from my past institute. This is 35-year female. She was from Rajasthan, Jaipur, Rajasthan. She was a homemaker, and she had a history like in 2014. She had a history of sudden onset weakness in the left half of the body while she was working at home, and she got admitted. This is the MRI during that time. Somehow the treating panel of doctors thought it after extensive evaluation they don't find anything very conclusive. So probably they thought that time it could be an seronegative APS, and she was started on warfarin for her symptoms, and she recovered over 1 month. And the natural history in Indian patients is stopped everything and stopped follow-up even. And she was doing well. In fact, in 2015, she developed paresthesia of the left first, second, and third finger. She was diagnosed as posterolateral medullary syndrome related to related neuralgia, but somehow there is an unequal pulse. So the treating doctor ordered for an angiography, and there was 100% occlusion of the left ulnar artery, and that was subsequently managed with balloon angioplasty of the left ulnar artery. Other than that, she was doing well, and she was not on any regular medication. In 2016, she developed diplopia and vertigo along with headache, which improved over 1 week. So she took some symptomatic medications, including Vatin and all those things for 1 week, and she recovered. No other symptoms. In 2017, she developed two small nodules over the left endoachilles, which on scratching she developed into the ulcer, which was not healing over last 5 months, and that was the point of time when patient got referred to us for further evaluation. On taking detailed history, there is no history of any constituent symptom, joint pain or pain abdomen. There is no history of photosensitivity, malarious, oral ulcer, alopecia. So there is nothing to suggest any underlying connective tissue disorder. Importantly, she had obstetric history was interesting. She had 2 kids, both premature due to pregnancy-induced hypertension or preeclampsia, and one history of spontaneous abortion at first trimester in 2009. Family history, her father had a history of stroke at the age of 65 years. So this is the picture of the ulcer over the endoachilles. So she was more concerned that time due to this non-healing ulcer. Other than that, she had no other much problem. So general examination was apparently normal. Only there was lividor rash involved in the hands and feet, and there's this partially healed ulcer over the left endoachilles. The rest of the examination was normal. Among the investigation, other than raised ESR and CRP, the rest of the investigation were non-remarkable, including the arterial Doppler of the limb, which was normal at that point of time. All other procoagulant workup was done. This was non-contributory. So in database, we had a 35-year lady who had pregnancy morbidity, hypertension, ischemic CVA, and non-healing ulcer and lividor rash. So we came with the possibility. Still, that point of time, we were thinking whether we are dealing with a seronegative APS, though initial evaluation was negative. We thought whether it could be an Sneddon syndrome because having both CNS involvement and lividor rash, though lividor racemosa is the most classical for the Sneddon syndrome. And in view of this non-healing skin ulcer, we kept a possibility of data to pan. So if you look for the seronegative APS, we reviewed what could be the possible cause of seronegative APS. One could be the lab problem. Another previous positive and now become negative. So that is not in our case. Another thing, it could be a wrong diagnosis. So seronegative APS experience is not very good in most of the series. So we thought whether we're dealing with something else. So we kept a possibility of Sneddon syndrome at that point of time, but by definition, SNIDON is a non-inflammatory vascular problem. So we had a suggestion for this raised ESR and CRP, which is not fitting with the classical SNIDON thing. And also, we cannot explain this non-healing ulcer. So that cutaneous ulcer lets us think of something, we are dealing something else. So when we reviewed the clinical spectrum of the ADA2 deficiency, so there are lividoreticulation, lividoracemosa, and non-healing ulcer, along with ischemic hemorrhagic or hemorrhagic strokes are reported. So that was the clue that persistent non-healing skin ulcer make us thinking of whether we are dealing with a Data-2-10. Biopsy showed the septal paniculitis, but there was no definite evidence of any vasculitis, and there was no artery which included in the biopsy that they can comment on the pan-associated vasculitis. So this point of time, the database was, there's a pregnancy morbidity, hypertension, ischemic CVA, non-healing skin ulcer, which by biopsy showing paniculitis, septal paniculitis, there is a raised ESR. Family history, it's plus minus like 65 years, can have an ischemic stroke and livedoid rash. So though pregnancy morbidity was not reported previously with any ADA2 pan, that was very odd for that. Still, we sent ADA level for evaluation. The enzyme was deficit. If you can look this, these are the carrier levels. These are the controls. Controls has 127. So she had only 10, and this is a mother's sample, which is in the carrier range. And subsequently, genetic evaluation also done. And this genetic testing confirmed the diagnosis, and the patient has an heterozygous missense variant at exon 4, and mother is also carrier. And the mutations found in these patients were novel mutation not reported previously. And we started on, she was started on adalimumab 40 milligram every 2 weeks. And this is the follow-up clinical picture after 2 months. There is definite reduction in the size of the ulcer, and patient was doing well. Subsequently published this case in Oxford Rheumatology. And so I think there is some point we should think of this kind of ADA2 deficiency, because still now there is no reported case from the EZRA. So we are missing the Data-2 deficiency cases. And now we can do testing from our institute also with the help of Alkandu sir. We have a collaboration with the Boston, the Pui Lee and Queen Zhao, who can do the genetic analysis. We can send sample to them directly. So if anyone having any suspected patient, then we can help them for confirming the diagnosis by both doing the enzyme level and genetic analysis. Thank you.
We still do not have any questions from the audience, so the experts can put in their comments in. Mishra sir may be wanting to say something.
How do you explain the transient visual and visual deficit in this case? He had a 1 week vertigo and visual. How do you explain that?
At the time when she came to us, there was no residual damage, but EIN is reported with. We had another patient who had only EIN who had a Data-2-10 subsequently, but there was no residual, nothing we could find that any damage was there, but we couldn't find anything residual there.
And did you have actigraphy studies of the abdomen?
Yeah, it was absolutely normal.
There was no. Okay. So the only clue was a raised ESR and CRP with a non-healing ulcer.
With the CNS involvement. So if someone
you could have diagnosed as cutaneous pan also.
That is the standard dictum. When a pan diagnosis is not matching or is not responding, one should thing for DADA 2, yeah. And we have already started sending samples, 3 or 4 samples we have sent there from our center. So people who are interested and plan to send sample can send through us there. Yeah.
How do you send sample? You extract the DNA and send?
Yeah, for genetic analysis, we extract the DNA and send, and for this, we send the serum sample.
Serum samples,
yeah. Okay. So
can I have one
latch on to, yeah.
Yeah.
Say, definitely now Dada has become the flavor of the day. Everybody is thinking about Dada. I'm not sure of the way we're overdiagnosing cases. Professor Mishra will tell me, because this is certain thing that everybody talks about Dada for any things they cannot explain. Conventionally, when you see a young lady presenting with these kinds of ischemic deficits, did we do a test for protein S, protein C? Standard things were done.
I thought we have tested for those things, and everything was normal.
And the other thing was even the ESR-CRP was not very high. I mean, you can, in a vasculitis, you expect a very high level of CBC, platelet, TLC, and neutrophil. It was not there, and the CRP was just borderline high.
Yeah.
So it's extremely difficult to think about a vasculitis with these kind of picture. Do you think it is being overdiagnosed?
Probably, sir, we are underdiagnosing.
So I thought like Jack being overused. I thought Dada is being overdiagnosed. I think Professor Mishra will be able to. He belongs to my school of thought sometimes. I follow him.
Yeah, in an adult, one has to be careful. I mean, you have to have that extra sense to pick up a case. But as you said, it is better to be in the order of the day than left out. So
right.
So if Alakendu Da has gone into a Boston collaboration, what's wrong?
So why the question is why we can't do that mutation here in India?
We are trying at the genetics.
Because Kalyani has a full genetic.
We have already started talking with them. Yeah, Partho Majumdar we are in touch with him. Yes.
That's one, because I know a lot of centers are doing genetic mutation. I mean, should not be a very difficult task to do.
Yeah.
Giving people in US and UK our patients and allowing them to do. The other thing is, how do you get permission to export biological material when ICMR and the health ministry has told that you cannot send biological material?
Yeah, there's a lots of procedures and the letters we have to send. They have sent us a requesting letter. Then SAR has made all this arrangement.
Sir, there's some question in the chat box.
Yeah.
Audience, yeah. How there's a question from Prajna Anirvan, who says that how common is Dada 2 in the general population? Are there any clues to suspect in a patient? Are there any GI manifestations of Dada 2?
Yeah, but prevalence I can tell, because there is no prevalence study of Dada 2 nowhere in the world. It's just case reports and case series are there. And recently from India, 33 cases has been reported, but there is no cases from the East Zone. So that's why I thought we should discuss. So that
don't have a database, yeah. Okay, there's another question from Dr. Debashish, who says, what is Sedon syndrome?
I think it's a theoretical question. He can Google that. It's an vasculopathy with having CNS manifestation with livedo racemosa. So it's also another diagnosis. Probably we are not fitting, like it's a APLA kind of presentation, but we are APLA negative. These were the primary point of suspicion, and there is no inflammation. It's a vasculopathy more often. And the GI manifestation, Dada 2 can have very well GI manifestation, and the patients I have seen with Dada 2 with GI manifestation most of them has a very severe GI manifestation. There are necrosis and perforation like any pan patients, and we need to be very aggressive in because the primary point of suspicion of Dada 2 comes with if you cannot reduce the steroid dose. If, on just reducing the steroid dose, there is a disease relapse, or patient is not responding to the usual cyclophosphamide therapy. So that's the point of one should think for DADA 2, because these patients usually are very well responsive to TNFI. So we can save those patients. It also helps in reducing the steroid dose also. So I think that's very important. And
it's pertinent. Okay, there's a question from Dr. Nirmal Kumar Som, the first part of which you've already addressed. What's the prevalence of DADA 2? You have already said that. The second part, he says, how do you explain the ulnar artery occlusion in your patient?
Actually, we don't know what all DADA 2 can present. It's a kind of vasculitis that can involve as a part of vasculitic process, ulnar artery. I think it's a part of the vasculitic process only, but we don't have an explanation for all the symptoms. Like Sarah has asked why there is a transient vertigo. I have seen patients who had disease durations for more than 20 years, but he is doing absolutely fine without even any treatment, because he refused to take any treatment in fear of side effects. But till date, he is doing well. I don't know what future will be, but till date, more than 20 years, he is doing well.
So good piece.
One thing is that first question, I think that has to be explained properly. For a general clinician, when they should suspect that this patient may have actually this DADA 2 syndrome, what are the clinical features then? Not say the pain responding to, not responding to steroids or cyclophosphamide, that is fine. But what are the usual clinical manifestations when you suspect that this patient may have DADA 2?
In the adult, if someone having both CNS and cutaneous manifestation, that could be a point of suspicion. Both CNS, ischemic stroke. Most of the patients, what I have seen, have had ischemic stroke, ischemic events, and also non-healing ulcer. This combination, almost all the patients had this combination of both CNS and a non-healing ulcer. And primary thing which came to our mind, it could be whether we're dealing with APLA, with livedoid vasculopathy, or non-healing ulcer. But when all those things came out negative, and other features of the vasculitis like raised ESR-CRP, most of the DADA 2 patients had very high ESR-CRP.
Acute phase reactance.
Yes.
Then what sample did you send? I mean, for everyone to know once again.
This enzyme level to Boston for enzymatic activity, and genetic test to Hong Kong.
How expensive is the testing? How long does it take?
We are doing free of cost. We just need to the transport cost.
How long does it take?
It's 1 or 2 days after reaching.
Okay. Any more questions, Pradeep?
I think no, ma'am. We can go to the next case. Yeah.
Okay, that was a brilliant presentation, Arga. You've really put us into, learning a lot of things. So this is the last one for today. This is another 20 minutes presentation by Dr. Pradeep Patra, who is also an MD-DM in clinical immunology from SGPGI. He is an associate professor, Department of Immunology and Rheumatology at IMS and SUM Hospital, Bhubaneswar. So over to Dr. Pradipta.
Thanks, ma'am, and thanks, organizer, for giving me an opportunity. So I will discuss a case about a 66-year-old female who was symptomatic for last 6 months. She has presented with intermittent bilateral reddish rash in the lower limb and pedal edema and breathlessness. She was all right 6 months back. I started with pain and painful, non-tender swellings. The swelling was persistent throughout the day, was non-tender, and she was intermittently taking diuretics because of the breathlessness and the edema, and symptoms were partially controlled. But in October 2020, she presented with worsening of the pain in the left leg associated with the swelling in the bilateral lower limb and increased dyspnea, which was initially on less than 500 meters. So she got admitted, but there was no history of cough and fever. Because of breathlessness and pedal edema, 2D echo was done. 2D echo revealed restricted cardiomyopathy, and also there is moderate MR and severe TR. CRP and ESR was raised, hemoglobin was low, and creatinine is 1.04. Because of suspecting a cardiac failure, she was managed with the nitroglycerin infusion and BiPAP, because she has also a history of obstructive sleep apnea. And she was discharged with diuretic, nitrolong, and Plavidon MR. 2 weeks later, she again admitted with the same hospital with complaining of same swelling of both limbs and breathlessness. Now the rashes were painful and generalized, more in the lower limb, and patient is not able to walk. But at this time, the hemoglobin dropped from 8 to the 5.3, and urine showed proteinuria and creatinine, which was normal 2 weeks back. Now it is increased to 2.2. So nephrologist has done ANCA, both ELISA and IF, and ANA were negative because of anemia. He has been infused with 2 units of PEC RBC, and suspecting pulmonary renal syndrome, she is advised for the steroid low dose 15 mg and tapered over the 15 days. Then after lowering down the steroid, she got fever and more of rash, more painful in the bilateral knee joint. She is having cough, intermittent hemoptysis, and decreased urine output. But there is no history of cough and fever. On examination, patient was tachypneic, blood pressure was a little high, and the respiratory was 30 per minute. Pallor was there and bilateral pitting pedal edema. And macular erythema rash present all over the body. And black, if you see there is intermittently, you can see the blackish discoloration over the rash and painful on touch. No ulceration were there. Systemic examination wise, she is having bilateral vesicular west sound, was diminished in the intrascapular region, but diffuse crepitation were there, and pansystolic murmur at the apex, and P2 was loud because of the pulmonary arterial hypertension, no organomegaly or no focal neurological deficit. And lab parameter for last 1 month, you can see the hemoglobin was low, and at this time the 2 units of PEC was given, and in the second visit, the nephrologist has advised for the prednisone around 15 mg. After that, the hemoglobin was a little bit increased and creatinine was got stabilized. Then at this third admission, the lab report showed ESR was increased in comparison to second visit, and creatinine was 2.1 and proteinuria with active sediment. And ANA, ANCA were negative. Protein electrophoresis also done. There is no ambient, and because of proteinuria and raised creatinine, so scrub typhus, dengue was done. Both showed IgM was positive, leptospira was negative. So to reach a diagnosis, renal biopsy has been done because the acute, the rapidly progressive glomerulonephritis, and bone marrow biopsy to rule out any myeloproliferative disorders, lymphoproliferative disorders, and skin biopsy also done. Skin biopsy, there is no evidence of any suggestive leukocytoclastic vasculitis, and bone marrow also no evidence of plasma cell neoplasm, and kidney biopsy done to look for any cause of the nephritis. So kidney biopsy revealed it is MPGN type of glomerulonephritis, and there is thrombi in many glomerulus. Because ANCA was negative, so it thought of cryoglobulin vasculitis. Next, cryoglobulin and cryofibrinogen test was done, which then suggestive cryoglobulin was positive, and rheumatoid factor were also high, C3, C4 were low, and again, because cryoglobulin was came positive, so we did repeat HCV. HCV was again negative. We did that. You can see that your cryoprecipitated both in the serum and in the plasma. When you warm, this cryoprecipitated got dissolves. You can see this is dissolved. So we made a diagnosis of cryoglobulin vasculitis. The prevalence is around 1 to 1 lakh. Mostly it is due to the hepatitis C. Second most common maybe connective tissue disease, and idiopathy can be due to the 10 to 15%. Actually, cryoglobulin concentration is usually more in the type 1 in comparison to the type 2 or type 3. And type 1 cryoglobulin vasculitis is usually monoclonal, and type 2 mixed, type 2 and type 3 are mixed. Type 1 is mostly due to the lymphoproliferative disorders, and type 2 is because of the chronic viral infection, and type 3 is associated with the connective tissue disease. So the clinical manifestation mostly because of the type 1 is associated with the lymphoproliferative disorder. It is due to the hyperviscosity syndrome. So they mostly presented with the gangrene, necrocyanosis, whereas arthralgia, arthritis, and renal manifestation are more common in the type 2, and type 3 also mostly presented with the purpura, arthralgia, and neurological manifestation. What mostly differentiating from the type 1, type 2, and type 3, type 1 is monoclonal, that they mostly confined to the skin, kidney, and bone marrow because of the lymphoproliferative disorders, and type 2 and type 3 mostly they involve the peripheral nervous system and kidney and arthritis. Apart from that, the renal disease is mostly seen in the mixed cryoglomerular vasculitis, and whereas in type 1, it is mostly seen in the thrombotic disorders. Pulmonary manifestation again is more common in the mixed, not in type 1. Neuropathy, as I explained, is also common in the mostly in mixed type in comparison to type 1. And musculoskeletal, that is arthralgia, arthritis, myalgia, are more common in the mixed common. And you can see the fingerprint pattern in the electron microscope of mixed cryoglomerular vasculitis. And it is mostly some subendothelial deposits. And how to approach this cryoglomerular vasculitis? Initial immunosuppressive treatment, either you can go with the steroid with rituximab or steroid with cyclophosphamide or plasma exchange. If it is underlying associated with any infection like hepatitis C, then you start with the antiviral, then you go with the immunosuppressant. And for myeloproliferative multiple myeloma or lymphoproliferative, appropriate treatment also should be started. So mixed cryoglomerular due to HIV or HBV infection, antiviral therapy should always be initiated before or at the same time as immunosuppressive therapy. So when to start immunosuppressive therapy in cryoglomerular vasculitis? If there is organ involvement such as glomerulonephritis, digital gangrene, GI vasculitis, or rapidly progressive glomerulonephritis, diffuse alveolar hemorrhage, or heart failure. So it can present, cryoglomerular vasculitis can be asymptomatic 25 to 30%. In that case, wait and watch with or without antiviral therapy. If it is associated with without any organ damage, then you can start with antiviral therapy with or without glucocorticoid. If there is organ damage, then you can start with the B-cell depleting therapy and glucocorticoid. If it is rapidly progressing or life-threatening cryoglomerular vasculitis, then plasma therapy, glucocorticoid, and B-cell depleting therapy also indicated. Sometimes cyclophosphamide also people has been tried. So this is a study of a series of 240 cases of cryovas survey. They have compared with the different immunosuppressant for mixed cryoglomerular vasculitis, non-infectious mixed cryoglomerular vasculitis, which they have seen that rituximab and corticosteroid had greater therapeutic efficacy in comparison to the corticosteroid with cyclophosphamide. So you should avoid the rituximab if the patient is HIV infection who are not on ART, and patient on ART viral load is not suppressed, and hepatitis B infection who has not been on antiviral therapy. Then role of plasma exchange, as I explained, if there is life-threatening cryoglomerular like acute respiratory failure, diffuse alveolar hemorrhage, or acute intestinal vasculitis, and rapidly progressing glomerulonephritis who require dialysis. Then we have diagnosed this case as type 2 cryoglomerular vasculitis and restrictive cardiomyopathy. There are some case reports where the cryoglomerular vasculitis sometimes associated with the dilated cardiomyopathy or restrictive cardiomyopathy. And after treating with the methylprednisolone and rituximab, has rash and swelling also got subsided. This is the after treatment. Then lab parameters after treating, the hemoglobin has increased and creatinine also got improved. So prognosis-wise, cryoglomerular vasculitis, when there is involvement of the kidney, the survivability gets lowered in comparison to without involvement of any kidney. Now, what are the take-home message from this case will be? Not every rash is a simple. Look for the internal organ involvement and beyond the ANCA. And if multiple autoantibodies, like this patient has dengue and scrub typhus were positive and rheumatoid factor also positive, all are IgM antibody positive, then we should think of cryoglomerular vasculitis. Thank you.
Thank you for the brilliant presentation. If the experts have anything to say, maybe we start with that. Otherwise, we have a question from the audience.
Thank you, Pradipta. There are several, some of the intriguing feature is why did the hemoglobin drop? That is usually not explained, and the best thing would have been to do the cryoglobulin analysis. The cryoglobulin can be electrophoresed to find whether it is, and nowadays you can also immunofix, so you can know whether there is monoclonal or polyclonal, and that you did not say. Maybe your time was limited, but the best way to dissect out the cause of the cryoglobulin is actually to electrophorese the cryoglobulin and to do immunofixation on it. I don't understand why the hemoglobin dropped. That is a big intriguing thing, because he did not have type 1 paraprotein. In type 1 paraprotein, the hemoglobin drop can be explained by expansion of the B cell or the plasma cell in the marrow. But here it is a type 2, as you said. How do you explain the fall of hemoglobin and even the rise of hemoglobin? What could be the mechanistic explanation for that?
There is no evidence of, I totally agree with you, sir. There is no any evidence of hemoptysis also, and we did CT scan. There is no evidence of alveolar hemorrhage, and that's why she has been transfused initially 2 units of PEC RBC, and 2 local blood were negative. So,
and is there a report of scrub typhus can cause cryoglobulin?
Yes, that can cause cryoglobulin vasculitis sometimes. But this patient is also dengue also positive. False antibodies can be there. So,
okay.
So, do we go to the question from the audience, sir?
Yeah.
There's one question from Debashish Maikap who says, one clarification. I have one patient that has similar features like this case. I diagnosed it as Sedon syndrome. I have to re-evaluate for data. Thanks for your insight. It's a comment as a question as well.
Yeah,
do you have anything to say?
This is possibly in reference to the previous case, I think.
Yeah.
Was immunofixation done? I think I missed it. Shakir says it. I mean, we already discussed, I think.
Discussed this one, yeah.
So there are no more questions.
One more question. I have one question.
Yeah, sir. Sure.
Pradipta, this is more to do with internal medicine. You said restrictive cardiomyopathy with pansystolic murmur. There are 2 contradictory findings. A restrictive cardiomyopathy never presents with pansystolic murmur. Dilated cardiomyopathy presents.
Yes, sir.
And you said tricuspid regurgitation, mitral regurgitation. So obviously she was having a dilated cardiomyopathy rather than restrictive cardiomyopathy. That's one.
I discussed same thing with the cardiologist, sir. This reported by the cardiologist only. They are strictly. I also thought the literature also more about the dilated cardiomyopathy, and the cardiologist also is telling that no, that is diastolic dysfunction is there. So he's thinking of more of restrictive cardiomyopathy. And I personally went and discussed when he is reported of MR and TR. So I thought of same thing. So he's telling me because of there is diastolic dysfunction along with this valvular regurgitation. That's why he is thinking of more of restrictive physiology.
I'm not sure. I beg to differ.
That's not convincing.
It is not convincing. Number one. Number two, if you get a dilated cardiomyopathy, viral infections are very common. You can have this subclinical myocarditis followed by dilated cardiomyopathy, and this virus could have been one of the possible causes of cryoglobulinemia and the subsequent things. Did you analyze the type of anemia?
Type of anemia is anemia. Ferritin was quite high, sir.
I didn't see the picture, peripheral picture.
She was microcytic hypochromic.
So can you get microcytic hypokalemia because of increased hepcidin levels in an inflammatory disease?
Chronic disease can have microcytic.
So
Symptomatic for last 6 months.
Professor Mishra was asking you, can you explain anemia? If you got a microcytic hypokalemic anemia.
The rapidly lowering,
but it was a rapid drop in the hemoglobin.
That is the concern. Yeah.
That was odd.
Did you do a stool for occult blood?
Yes, sir. That is negative, sir. All malignancy workup was done because to rule out any underlying type 1 cryoglomerulonevascularization.
And I also think patient had congestive cardiac failure.
Yeah, that's why initially second admission she was infused nitroglycerin, fluvidone, all. She was admitted under cardiologist, then nephrologist, then rheumatologist.
So when you have a congestive cardiac failure, can you have a congestive intestinal state with the absorption of iron can be defective?
But ferritin was quite high.
Ferritin was very high, yeah. So more of anemia, chronic disease possibly.
Was only not explainable is why there is rapidly lowering of hemoglobin.
Rapidly lowering, yeah.
Yes, sir.
Ejection fractions were all preserved. Ejection fractions always preserved.
Yes, sir. Yes, sir. Yes, sir.
This MRTR severe pulmonary, right? Severe pulmonary arterial hypertension. Yes, so that's again very odd, very odd.
Okay.
Nice case. Enjoyed the case.
Thank you.
Thank you, Pradipta. It was really enjoyable. We all shared and learned quite a bit. So now do we move into the next? Sir, do we move into the next? Sir?
Yeah, yes, sir.
Of course.
So, yeah, we have the CPC, which is going to be a 25 minutes presentation.
I have one suggestion, Dr. Madhumita.
Yes.
Because the case belongs to us, the discussant should be Professor Mishra and Dr. Alakendra Ghosh. They can discuss
for the CPC?
Sure.
Okay, so that's how we will proceed. It's going to be presented by Dr. S.R. Tripathi, who is MD DM, Assistant Professor of Rheumatology at SCB Medical College, Cuttack, and Dr. Kamodi Patnaik, who is an Associate Professor of Pathology, BB Medical College and Hospital, Balangir, Odisha. So here we go. You have a 25 minutes allotted to you.
Good evening, everyone. Am I audible?
Yes.
Okay. The screen is visible?
Yes.
Okay. Thank you, ma'am. I thank the organizers for giving this opportunity to SCB Medical College for presenting the CPC. So we will be presenting this case. This patient we have had since September 2019, and it was a topsy-turvy turn that we had with the patient, and we finally diagnosed in the month of July, August, when the pandemic was at its peak. It has nothing to do with the pandemic though. The patient, 24-year-old male, non-diabetic, non-hypertensive patient, presented with left orbital swelling for 1 month, right parotid swelling for 1 month, and multiple skin nodules over the abdomen for 3 weeks, and a fever continuous high grade for the last 1 week. There was no history of arthritis, uveitis, skin rash, dry eyes or mouth, muscle weakness, cough, hemoptysis, oliguria or hematuria or pedal edema, neurological complaints, any bladder and bowel dysfunctions. The family history, there was this both expired. The mother had expired out of jaundice. The cause was not known. The father also expired from a separate cause, which was also not known, but he had a history of CBD with calculus colonitis. This is our index patient. He has 3 or 4 other sisters. One of them had pulmonary COX 20 years back, while the rest of them were absolutely normal. Personal history, no addictions, habituations. He is unmarried and Mason by occupation. On examination, the patient was febrile with a recorded temperature of 100 degrees Fahrenheit. The vitals were stable. No pallor, icterus, cyanosis, clubbing, lymph node enlargement, or pedal edema. There was a left periorbital swelling that you can see here. It was non-tender and non-erythematous. There was a right parotid gland enlargement, which was mildly tender, firm in consistency, but the overlying skin was normal. There were multiple firm cutaneous nodules with irregular margins around 3 to 5 centimeters in size over the abdomen, back, and some of them on the shoulders, but they were non-tender. Unfortunately, I don't have a photograph of those nodules. The rest of the systemic examination did not reveal any abnormalities. So with this short history and examination, we had kept these differential diagnoses, the first being sarcoidosis, the others being IgG4 disease, malignancies such as lymphoma, tuberculosis, Wegener's granulomatosis or GPA, and Sjogren's syndrome. The lab evaluation turned out that CBC was normal. The ESR and CRP was surprisingly again normal. In the LFT section, we had only mild transaminitis of AST 79 and ALT of 90. Rest of the parameters were normal. The fasting blood sugars was normal. The KFT has not been mentioned, but the urea and creatinine is normal, including the urine and stool examination. Because we had kept Sjogren's and GPA in the differential diagnosis, we had also done ANA, rheumatoid factor, and turned out to be negative. The patient was carrying with him certain imaging reports. There was diffuse enlargement of the right parotid gland with parenchymal and surrounding edema. However, there was no evidence of any gland calcification. The subcutaneous tissue plane was hazy with edema on the right side of the face at the subcutaneous tissue plane, and the probable diagnosis was parotitis. Left periorbital and intraorbital fat plane haziness was present, and that was suggestive of inflammatory with no definite comments on any necrosis. Mildly enlarged lymph nodes seen in the right side, level 1B and 2, measuring 12 mm, with no evidence of necrosis on the imaging, and that was also presumed to be inflammatory. With these evidences, we ordered for a histopathological examination of the nodules, FNSC followed by punch biopsy, and FNSC of the right parotid gland. With this, I would like to hand over to our pathologist to describe the histopathological findings of the FNACs of the parotid gland and cutaneous nodules, as well as the punch biopsy findings. Over to Dr. Komudi. Madam.
Ma'am, you have to unmute yourself. You're muted.
Unmute and share.
Is it visible now?
Yes.
Okay, thank you, ma'am. Good evening, everyone. So I will go for the microscopy of the case that Dr. Soumya has described. This is from the screen nodule. The FNAC was showing mostly histiocytes with epithelial cells.
Your slides are visible.
Not visible. Slides are not visible.
No.
You are visible, but not the slides.
Madam, first, please open the slides in the background and then start sharing. That will be better.
Yes.
Yes,
now you're
it's
visible.
Yeah.
Now it's okay?
Yes.
Yeah.
Thank you. So on this screen nodule, the FNAC was done, and mostly it showed histiocytes, epithelial cells, and few lymphocytes admixed with fibroblasts. So here what I saw, this is actually a local view. These elongated cells with some indentation were called epithelial cell clusters, and some polygonal cells lying here and there, hypocellular smear. Those are histiocytes, and lymphocytes were also admixed with it, and some these are all fibroblasts, and no necrosis were evident. So with the impression, it is suggestive of granulomatous lesion. Then biopsy was done in that nodule. So the lesion was a dermal pattern lesion, and epidermis was not involved. And in the superficial dermis, upper dermis, there is perivascular mononuclear lymphohistiocytic infiltrate. So this is the epidermis. And in the dermis, in the upper dermis, perivascular lymphohistiocyte aggregates were seen, and the biopsy was a bit superficial, but the granulomatous region could not be excluded because in the FNEC we had seen definite granulomatous lesion. So we advised for a deeper biopsy, and then from the parotid, the FNAC was done. There are clusters of, I have not saved that slide because it was looking a bit normal. So clusters of benign salivary ductal cells and stromal fibroblast cells on a hemorrhagic background. And it was admixed with lymphocytes and histiocyte. Actually, the conventional diagnosis what you give in these cases as non-specific salivaritis. But the atypicality with this that the histiocyte population was prominent there. So granuloma could not be excluded. So this is the finding in your FNA from parotid, and orbital FNAC was swelling by FNAC was not done. Thank you, ma'am. Over to Soumya to continue. Anything to ask?
Thank you, ma'am. Is my slides visible now?
Yes.
Yes, ma'am. So with the histopathological findings of prominent histiocytes in the cutaneous nodules as well as in the parotid gland, we thought of the various granulomatous conditions, and the most common granulomatous disease in our country is Cox. So the first thing that we do in a knee-jerk basis is MON2. It turned out to be negative. We did chest X-ray and HRCT scan to look for evidences of pulmonary Cox as well as sarcoid, and it was again a normal CT scan and chest X-ray. The serum calcium was normal, but the serum angiotensin converting enzyme was 110, which was around more than 1.5 times the upper normal limit. So with a negative MAR2, raised serum ACE, granulomatous with no evidences of caseations. This was our summary: a 24-year-old male with subacute onset fever, periorbital and intraorbital inflammation, left parotitis, multiple cutaneous nodules with subtle evidence of granulomatous lesions, negative MAR2, raised ACE, and mild transaminitis. So with this, we want what the panelists are thinking and to compare whether we have thought in the same lines or in different lines.
Yeah, Shomo, nice presentation. I think this is one of the real challenge in clinical practice when patient presents with this type of nodularity with the lymphadenopathy. TB sarcoid versus IgG4 related disease are the usual scenario. And we had one or two patients where we faced with this challenge. AC in one patient was very high, in one was not high. Started treating them in terms of sarcoid, ultimately landed with a tubercular etiology, and patient required one of the nursing staff. We had a lot of trouble, ultimately she recovered. So this is the clinical situation, but I think connective tissue diseases as the background were reasonably excluded. So Dr. Patnaik, do you have any impression in terms of difficult tuberculosis in these patients, or you certainly have excluded that one from histopathology? Need to unmute, Dr. Patnaik. Yeah.
Actually, I had mentioned in the slide that there was no necrosis in the background. So tuberculosis was excluded, but it should be kept in mind because in a tropical country, tuberculosis first should be normal.
Right, right.
So shall I continue, sir?
Yeah, Shomo, continue.
Yes.
Professor Mishra can say something. Professor Mishra, you have any opinion whether we have gone correctly or incorrectly?
No, actually, the pathological information was is inadequate because the FNSC only is suggestive of histiocytes and lymphocytes, and unfortunately, in the histology, we do not have a definite granuloma because they advise for a deeper biopsy of the skin nodules, and of course, the parotid gland FNAC also is, half convincing. Sarcoid, there are some, we consider three diseases usually: sarcoid, TB, and lymphoma. When we encounter this kind of problem, sarcoid is generally a bilateral disease. The parotid gland enlargement is generally a bilateral disease, and the skin nodules are not typical of a cutaneous manifestation of sarcoid. And you have a well-defined lesion over the nose, or you have erythema nodosum at the beginning of sarcoid. So this is not typical, the subcutaneous nodule. The parotid gland swelling, yes, but it should have been bilateral. And periorbital swelling has been described in sarcoid, but again, it is of bilateral nature. So, and the ACE level now is actually contested that it is not a very specific diagnostic marker of sarcoid. So, and since you have kind of excluded TB on the basis of a Monte test, which is itself fallacious these days, I think we should have gone in for a deeper biopsy of the nodule, deep dermis biopsy nodule, as the histologist or the pathologist suggested. But sometimes we are we are satisfied with whatever is possible. I am not convinced of the diagnosis of the sarcoid, primarily because of unilaterality of the parotid gland swelling and the orbital gland swelling. But I don't know, today's evening has been a case of rarity. The 6th case in the world, the 28th, that was the first case, was 28, what Sakir presented. And God only knows how many primary X-linked hypogrammaglobulin with polyarticular JIA. That is the 6th case, yes. So we never know. This could be anyone's guess.
So can it be still an IgG4 related disease? Because parotid swelling, orbital swelling, some skin nodules, we have not done a biopsy still. So can it be
yeah, it's a good point. The ESR was 5. IgG4 related disease does invoke an inflammatory response, and it is amenable to steroid. But it is your guess versus my guess.
And one point I want to say, because the common variable immune deficiency patients can present with sarcoid-like granulomas. So I think we should work up for CV immune deficiency also, like CVID, because sarcoid-like granuloma, this is not clearly sarcoid, but sarcoid-like granulomas. So this can be a presenting manifestation also.
That's also in the chat box from Dr. Sanjeev, whatever Trubo has just said.
And one thing, sir.
Yeah.
Sir, in the FNA organ biopsy, we have not seen any lymphoplasmacytic infiltrate in that dense manner. Actually, plasma cell we have not seen, and it should be if it is IgG4 disease, the lymphoplasmacytic infiltrate should be dense with fibrosis. And those things, the plasma cell we have not seen in the FNAC at least, and lymphocytes also. So IgG4 cannot be thought of FNA.
So from histopathology, IgG4 and tuberculosis are strongly excluded, you think?
Yes, sir. But tuberculosis actually necrosis. It may not show necrosis always.
Tuberculosis may not show. Yeah, that's the challenge with a diagnosis of sarcoidosis on steroid responding so well. Yeah, Shomo, you just continue.
Okay, sir. With all points well taken, and we will look into that CVID aspect of that patient as well, because we still have some challenges even after diagnosing. Let the story unfold further. The treating team's diagnosis was sarcoidosis, and we started on 1 milligram per kg body weight. And there was a dramatic response of the subcutaneous nodules, parotid swelling, and the periorbital swelling, which all resolved within the next 1 month. We could not give any DMARDs because the liver enzymes were raised. And so we tried to taper down the prednisolone as much as possible before we started the DMARDs. And over the next 8 weeks, we could taper to 10 milligram per day. And we maintained on 10 milligram per day for the next few months. And UDCA was given for the raised liver enzymes. In February, the patient again relapsed with fever. This time it was continuous and high grade again for 5 days. There were no localizing signs of infection. However, the patient had stopped medications for the last 10 days, which could be one of the contributing factors. The lab evaluation in February, this time we had a raised CRP of 18. By February, COVID had already entered our nation, so we did the COVID test. The COVID test was negative. The MPICT and dengue, which are the routine stuff which are done in our medical colleges for any patient with fever, they turned out to be negative. The liver enzymes had raised again to smaller extent of 133 and ALT of 148. The ALP, protein, albumin, rest of the parameters were normal. The urine routine microscopy had 6 to 8 pus cells. But this is on borderline. So whether it is UTI or not, we don't know. The culture was negative. The resident had started on the fluoroquinolones, and we advised to restart the prednisolone, which the patient had stopped for the last 10 days. With this combination of ciprofloxacin and prednisolone, the patient responded, most likely to the restarting of prednisolone. The UDCA was continued. In April 2020, again, the patient relapsed with a third bout of fever, and this time he had some abdominal discomfort and anorexia as well. This time the investigations, it is important to note that from September onwards, there has been a slow but constant decline in the TLC count, 8,800, 4,500, now it's 4,000. The CRP is creeping up, 5.6, 18 and 38, but the ESR is still 5, 6, 6, it is not budging. The liver enzymes, they are also creeping up slowly. AST has gone up to 173, ALT is 103, and the alkaline phosphatase for the first time is increasing. And rest of the examinations were normal, including blood cultures and urine cultures. With this, the first thing that a rheumatologist thinks is a falling WBC count of normal ESR and a rising CRP with some transaminase is macrophage activation syndrome. So we went ahead with a bone marrow aspiration study, and that turned out to be normal, which can come up in at least 50% of the patients. Unfortunately, during those times, we did not have access to ferritin, triglycerides, and fibrinogen in our hospital. Temporarily, the biochemistry department was off. The radiologist, they said that ultrasound was hepatosplenomegaly. There was grade 2 fatty changes, which added to the confusion whether these raised enzymes were part of disease activity or they were just part of the fatty liver. The CCT again showed hepatosplenomegaly. Initially, if you remember, we had lymph nodes in the cervical region. Now there was evidence of small lymph nodes even in the para-aortic and aortocaval nodes. But again, the repeat CT scan did not throw up anything. It was again normal. Management, we thought that this was again active sarcoidosis, so we increased the dose of prednisolone to 20 milligrams from 10. UDCA was continued. With 20 milligrams, the fever subsided. However, HLH was still in our minds, and we thought that we'll observe the patient and ask him to show up after 1 month. During Corona, the patient did not show up until and unless he had a severe problem. So after April, May was gone. In June, he returned with fever of 2 weeks. And this fever was associated with jaundice for the first time. Now he has jaundice, but there were no prodromal signs of viral hepatitis. This was a non-fluctuating jaundice with high-colored urine, suggestive of some cholestatic pattern. There was no pruritus, vomiting, GI bleed, or altered sensorium. There was weight loss. And because he had not been able to access us, he had tried herbal medicines and Ayurvedic medicines locally, before reporting to us. On examination, the blood pressure and pulse were relatively okay, but icterus was clearly evident. Hepatomegaly was present with a liver span of 18 centimeters. Splenomegaly was present with the tip palpable. Rest of the systemic examination was okay. With this, the differential diagnosis of the treating team that we had, we thought that is it hepatic sarcoidosis which is not responding to steroids, whether there is some underlying infective etiology which you are missing, such as tuberculosis or chronic viral hepatitis. Are we missing out lymphoma or malignancy which could have suppressed by the steroids and now it is flaring up? Or did we miss autoimmune hepatitis on the first go, and whether the drug that you might have taken at home, indigenous drugs, could have caused that liver injury? So lab evaluation in the June when he reported to us, the WBC count had further dipped to 3000 and the peripheral smear showed no abnormal cells, but leukopenia was evident and rest of the examinations was okay. Regarding LFT, this time the bilirubin was 7.2 total with a direct of 6.0. The liver enzymes had shot up to AST more than 480 and ALT of 260. The ALK phos had shot up to 1201. GGT was raised, confirming that yes, this is all a cholestatic pattern. The creatinine was normal and protein albumin, although not mentioned, were within okay limits. So with this lab evaluation, we did the other examinations, urine, stool, blood cultures, routine stuff. They were normal. This time the ACE levels were normal. Calcium was within normal limits. All the viral markers, hepatitis B, C, HIV, HAV, HEV, EBV, and CMV, all turned out to be negative. And the repeat ANA was also negative. The radiologist, they gave us evidence that there was some subcutaneous edema of the anterior abdominal wall localized to those nodular swellings, but the nodules are not very prominent now. The hepatosplenomegaly was present, but they gave normal liver echo texture. Previous ultrasound, they had shown fatty changes. So again, we did a CT scan and the CT scan also showed that yes, there was fatty infiltration. So that confusion is still present, whether it is all fatty liver or there is some inflammatory disease going on in the liver. The gallbladder was normal, common bile duct was normal, splenomegaly had increased to 16.5 centimeters. There was some evidence of minimal ascites, but there was definite evidence of lymph nodes, especially in the region of porta hepatis up to 13 mm. Previous ones were subcentimetric. So this means that the lymph nodes are actually increasing in size and there was minimal pericardial effusion. So the patient had reported to us on 20th until 1st July, almost the patient was neither worsening nor improving. The patient was continuing the prednisolone 20 milligrams and the routine antibiotics. The WBC count was stable around 3,500 and the liver enzymes ALK phos had just starting to settle down. But the next week, the TLC again dipped, the liver enzymes started again worsening, and we increased prednisolone to 40 milligrams and took a gastroenterology consultation. The gastroenterologists, they did a MRCP, which showed the same findings. They confirmed that hepatosplenomegaly was present. There was no intrahepatic biliary radical dilatation, and there was no portal vein involvement. On the next week, there was a second cell lineage started dropping. The platelet count has come down to 42,000 and the CRP has gone up to 48. The temperature had shot up to 104 degrees Fahrenheit. It was at this point that we ordered for a repeat bone marrow and started thinking of HLH again seriously. So we have done a liver biopsy on 8th with the gastroenterologist and a bone marrow aspiration on 14th. So this I've already told. So the clinical criteria for HLH, the 2004 and 2009 criteria, in both criteria, we had the clinical part, 3 of the clinical, fever, splenomegaly and cytopenias, and hepatitis in the 2009 criteria, but we still did not have the other parameters. So what we did, we ordered for the triglycerides, ferritin, fibrinogen and sodium levels, and we also ordered for a bone marrow. The biochemical parameters were all in support of HLH. Ferritin was raised, fibrinogen was low, triglycerides were high, and there was supportive evidence of hyponatremia. This is the new H score that is being used, and it has been come into limelight with COVID. Even the H score that we applied with the clinical criteria that we had, it contains one immunosuppression background, 3 clinical criteria of temperature, organomegaly, and cytopenias, and remaining 5 biochemical characters, ferritin, triglyceride, fibrinogen, AST, and 1 tissue sampling, that is bone marrow aspiration. With the exception of bone marrow, we were getting a points of 287. So almost the HLH criteria was satisfied, and we were 99% probable that we are dealing with HLH. So we started the patient immediately on methylprednisolone. This is the summary: fever more than 103 Fahrenheit, hepatosplenomegaly, hyperbilirubinemia, transaminases, leukopenia and thrombocytopenia, that is 2 cell lineages, low ESR despite high CRP, hyperferritinemia, hypofibrinogenemia, and hypertriglyceridemia. So our diagnosis was sarcoidosis on the background with involvement of cutaneous, periorbital, parotitis, and hepatic with complication of HLH. Now, we know that pathologists are the vital cog, and they shed light on the truth that we are missing. So over to Dr. Kaumudi to shed light on the liver biopsy sample and the bone marrow aspiration report.
Thank you, Dr. Samya. Now the slide is visible, the first slide?
No.
So reopen the slide first and then share.
I reopen first. Now it is visible?
Yeah. Yes.
Should I start?
Yeah.
Thank you. So now I'll proceed to the liver biopsy down in that case. So what you see here, it is the entire length of the liver biopsy, which is fragmented into 2 while processing in the lab. So what we see here, there is mild to moderate loss in architecture of the liver, but there is no nodule, definitely, no nodule formation. So, but the liver looks bubbly. Bubbly appearance is due to steatosis. And second thing, what we appreciate, some focal lesions scattered throughout the liver fragment, scattered lesions, focal lesions scattered throughout the liver fragment. And in the next slide, and what we see in the steatosis, more than 66% of the liver are showing steatosis. These are focal lesions. So these are the focal lesions in a bit higher power. So there are the circumscribed lesions, and they are occupying the portal and periportal areas. And still higher power, what I see, these are all epithelial cell collection in an aggregate, in tight aggregate circumscribed collection of epithelial cells. How we identify the epithelial cells? These are the oval elongated cells with indented nuclear outline with pale eosinophilic cytoplasm and intestine margin. They are all epithelial cells. Along with that, some polygonal histiocytes were also present. And what we see here, some structures, that is the bile plug inside the ductile. One bile ductile is here, another bile ductile is here. Here, bile ductile containing bile plug. Here also another bile plug. So this is the portal area, and this is the branch of hepatic artery. So this is when we see clusters of epithelial cell, aggregates of the epithelial cells in circumscribed manner, that is called a granuloma. So what is hepatic granuloma? It is a compact organized collection of mature mononuclear phagocytes that may or may not be accompanied by accessory features such as other inflammatory cells like lymphocyte plasma cell may or may not be present, or there may not be necrosis, or there may not be scarring. That is the typicality of hepatic granuloma from other granulomas found in our body. So coming to still higher power, what we see, again that granulomatous region, one epithelial cell is here, and some Kupffer cell hyperplasia also present somewhere in the sinusoid, but this is the focal area. So the blue arrow, it points towards eosinophil. Eosinophils are invariably present in all the granulomatous areas. And one plasma cell is seen over here. The plasma cell is not that frequently seen, but the eosinophils were seen. This is another area in that liver, so in this type of granuloma. Again, another focus in the liver also showed granulomatous area in the portal area. This is the branch of hepatic artery. And here also, portal area, this is the portal vein and hepatic artery, and some lymphocytes are aggregating, and some Kupffer cells also present towards the parenchyma. Here is another area that is showing again eosinophil and a circumscribed collection with some epithelial cells, histiocytes. And in this region, it is the branch of hepatic artery, which is I marked some infiltration of neutrophil in its part. On its higher power, so the neutrophils and eosinophils, some neutrophils were also present, and eosinophil is infiltrating into the wall of this branch of hepatic artery. So this is taken as early lesion of granuloma, early granulomatous lesion, because it's not that well circumscribed. Then apart from these granulomatous areas in the liver, another prominent feature was bile plug. So this is from the hepatic parenchyma lobule, where the canalicular bile plugs are seen over here. The canaliculi containing bile plug. Again, that this is canalicular bile plug, canalicular, the yellow arrows. It was a prominent feature. Along with that, there was feathery degeneration of the hepatocytes. Means the bile inside the cytoplasm of the hepatocytes, and hepatocytes are increased in size and is rarefied. So feathery degeneration of the hepatocytes are seen along with the canalicular and hepatocytic bile plug. Another area showed bland cholestasis. Bland means it is not associated with any inflammation. Only this region totally is cholestasis region. Bile plugs in the canaliculi. Again, here also, what I find, again bile stasis. These areas are bile stasis area, and this area shows feathery degeneration. That is the hepatocytic bile. Here also, bile inside the cytoplasm of the hepatocytes. So for which we suspected some chronic cholestasis in this liver. So we went for one special stain, that is opsin stain, which stains the copper binding proteins. So that is seen in chronic cholestatic liver disease. Apart from that, another pathology was seen in this liver, which is more prominent in the scanner, that is the steatosis. And this steatosis were of macrovesicular steatosis. And here is one fatty cyst has been formed. And this brown arrow shows ballooning degeneration of hepatocytes. The black arrow shows the locular inflammation. So taken together, steatosis, ballooning degeneration, and locular inflammation, this could be steatohepatitis. So steatohepatitis was also present in the liver tissue. And here prominently ballooned hepatocytes with yellow arrows. All are showing ballooned hepatocytes, ballooning degenerative hepatocytes. Foci of lobular inflammation were also present in other area, for which there was transaminitis. And we went for a muscle trichome to establish whether this is a sarcoid lesion. But what is seen in sarcoid lesion, around the granuloma, there is dense collagenous scar surrounding the granuloma. But this is not evident in this our slide. What we see here, this is a normal collagen present in the portal area. So this is a younger lesion, and no typical collagenous scar is seen in the special stain also. So the characteristic of sarcoid granuloma in liver, it is mid-portal or periportal, and granulomas of all ages are typically seen. And in our case, we have seen early and young granuloma. Old granuloma we have not seen because we don't find any dense collagenous scar in special stain. Summarizing it, predominantly portal and periportal area, non-cageating granuloma. Nowhere we have seen any cageation necrosis. Next, along with that, it is a sequelae of it, this non-cageating granuloma because it is present in the portal area. It has obstructed the bile canaliculi, so it has formed cholestasis. Another lesion is the second pathology, that is steatohepatitis. So both one non-cageating granuloma, cholestasis, and steatohepatitis are found. So what may be the cause of granuloma in this liver? There is a long list of granuloma. Mycobacteria we have excluded. Epistin was negative from that granulomatous area, and we may think of sarcoidosis, or because that is showing chronic cholestasis. Primary biliary cirrhosis has to be, primary biliary cholangitis is called, it has to be excluded, or the patient was giving history of taking ayurvedic preparation and prednisolone. Some drug induced liver injury also can show steatosis, granuloma, eosinophil, everything it can also show. So Jedinstein AFP was negative, and morphology patterns of different types of granuloma, epithelial necrotizing, non-necrotizing. But we find here non-necrotizing granuloma. Could it be sarcoid granuloma? So sarcoid granuloma is diffusely scattered throughout the liver. What we see in our case, it is portal and periportal. Yes, we have seen well-defined, compact and rounded aggregates in the older lesion, but we are seeing the early and the young lesion. It's definitely non-cageating, and it may have multinuclear giant cell. We don't see any multinuclear giant cells in our case. And occasional plasma cell eosinophils can be seen, but we are seeing more of eosinophil and occasional plasma cell, and it's early and young. And sarcoidosis is a prototype of all granuloma diseases, always a diagnosis of exclusion. Granuloma of 2 or more tissues with exclusion of all other known causes. And in the salivary aspirate, what I think, the needle might not have hit the that lesion. So we are getting histiocyte. Histiocyte you don't get in salivary. We get lymphocytes. Histiocyte is uncommon, but it was prominently seen. And skin nodule in the FNAC, we had seen the granuloma. And so liver we are seeing an orbital swelling. It is not, FNAC not done. So hepatic granuloma is clinically silent. Clinical attention given if the liver biopsy, if the cholestatic liver disease or total hypertension or abdominal liver tests are seen in the patient, but is seen in our case. So this is the typical sarcoid granuloma. It's from the book picture. I'm just showing sarcoid granuloma. It's again from the book picture. It's a large granuloma, macrogranuloma. Whereas because the common DD I bring here because eosinophil I am seeing, which is commonly seen in drug-induced liver injury, DILI, and but we are also seeing some eosinophil. So I brought this as the closest differential diagnosis. So this small granuloma, micro, this is macro, and this type of collagenation is expected in sarcoid, and it is in portal area, but the drug-induced liver injury is seen in the lobules, in the parenchyma. So drug-induced steatosis, steatohepatitis, especially by prednisolone, are considered as a rare form of injury, and no evidence of prednisolone role in granuloma. They don't form granuloma. They may form steatosis, they may not form granuloma. So in this hepatic granuloma, the sarcoid, drug-induced liver injury, and lipogranuloma, they form as differential diagnosis in this particular case. And in sarcoid is commonly portal, drug-induced lobular. Here lipogranuloma, how it is formed, the lipid gets excluded from the fatty hepatocytes, and it gives rise to granuloma by the host response. It's again lobular. Eosinophil can be seen, but it is predominant drug-induced. And the sarcoid well-defined macrogranuloma, whereas a drug-induced microgranuloma. Here it is ill-defined, but you find here portal eosinophil was seen and well-defined macrogranuloma type. Again, another good picture, and which shows this is a small granuloma micro, whereas this is our case, which is showing a larger portal granuloma. And this is in lobule, and but this is in portal area. Lobule because this is central vein. adjacent to it. Possibly hepatic granuloma sarcoidosis now we are thinking of. So just for completion's sake, PBC primary biliary cholangitis has to be excluded because it is also a chronic cholestatic disease with granuloma. So this is a book picture which shows the destruction of the bile duct epithelium by the granuloma. This is not seen in our case. So just one case report was there, clinically silent. This remains clinically silent. Elevated liver function test leading to liver biopsy in a patient with hepatic sarcoidosis may be caused by concurrent liver disease like drug-induced liver injury or fatty liver disease or other chronic liver disease. And they have shown this photomicrograph, a biopsy of patients suspected of fatty liver disease, so steatohepatitis and incidental sarcoidosis. It simulates our case. So our final diagnosis was hepatic sarcoidosis with NASH. Then about the bone marrow study, it was normocellular, the aspirate normocellular, but mildly depressed erythropoiesis and myelopoiesis were mildly depressed, and other parameters were within normal limits. No atypical lymphoid cells were seen in the bone marrow, but there are prominence of bland histiocyte engulfing platelet, mostly platelet and cellular debris, and other histiocytes, which is hyperplastic. There also they have engulfed the erythroblast, RBC were also there. No, the picture not taken, but this type of hyperplastic hyperhistiocytes were seen, and with erythrophagocytosis. So with these features, finally we this has a diagnosis of lymphohistiocytic hemophagocytic lymphohistiocytosis, that is HLS, correlating with high TG and triglyceride and high ferritin values with and bicytopenia. And this is the bone marrow study picture and its impression. Thank you. Over to Dr. Soumya to continue and correlate with the pathology.
Soumya, unmute.
Unmute.
So with the diagnosis of HLH and MAS with a precipitating background sarcoidosis with non-alcoholic steatohepatitis, this was the final diagnosis after the pathology reports came in. So we had already started methylprednisolone 1 gram per day, pulsed him for 3 days, and this was followed by cyclosporin 100 milligram per day to abate the HLH, and prednisolone was continued at 40 milligrams per day, and vitamin E 400 milligram twice daily was given for NASH. After 3 days of pulse steroid, the patient had become afebrile, the cell count had improved, the CRP had settled, but the liver enzymes expected it will take some time to settle down. So after 3 months of treatment, although I did not have that photograph of the nodules, I never thought I would require to present. But here you can see the areas of atrophy at the site of the previous nodules, and the parotid swelling was gone, and there was atrophy in the region adjacent to that subcutaneous fat adjacent to the parotid. Like Mishra sir was mentioning, it has to be a bilateral disease. So you can see here that we have bilateral cheek fat pad atrophy. So probably the patient was having subcutaneous and fat infiltrates in bilateral sites, which again goes in support of sarcoidosis now that we have a bilateral disease. So this is the summary of the patient. He came in September 19 with fever, periorbital and parotid swelling and cutaneous nodules, given prednisolone 40. In February with prednisolone test, there was a small flare. We gave again in April 20, second flare. Third flare in June, where he had fever of 104 and it was complicated with MAS and HLH. So we probably thought that the steroid that we were giving was forcing the HLH to go subclinical, and it finally appeared in June 2020. Now that the patient has received cyclosporin and methylpred, the HLH is gone. Probably the sarcoid is also settling down. That is why we have these atrophied sites and the fever is absent. The CBC has normalized, bilirubin has normalized. The transaminitis is still persistent, probably due to NASH, but unfortunately due to the longer period of steroids, the patient has developed diabetes. The patient on September was continuing on omnacotil 15 and cyclosporin. Now again, the patient has been lost to follow-up, most probably due to corona, or he will hope that he is all right. We tried to contact him yesterday but could not. Hope to see him soon. With these, the take-home messages are hepatic sarcoid can occur even in the absence of pulmonary involvement, which is present in more than 90% of sarcoid patients. Pathology plays a vital role in the diagnosis of hepatic sarcoid, which can be missed easily if not biopsied. And HLH is another complication. It is a rare complication of sarcoidosis. This has been a night of rare diseases, and it can also be missed easily. So thank you all for a patient hearing. I know we are running short of time, but I would like to acknowledge the Department of Gastroenterology for the constant support in our clinical management, including the liver biopsy of the patient. Thank you.
Yeah, it's a brilliant, exhaustive presentation. Yeah, you did pick up the diagnosis after a lot of, workup. I hope Alakinder Ghosh sir is going to put in his comments. There are no questions from the audience.
Yeah, that was a great clinical journey, because the patient presented with a fever and lymphadenopathy with the suggestions of, as we had discussing, TB, sarcoid, other granuloma, IgG4 related disease. But in between, the development of macrophage activation syndrome in the setting of sarcoid is really not common. And liver histology documented. But when a patient presents with a cholestatic liver disease in a setting of granuloma, we usually expect to have underlying correlative clue of that histologic pattern, which were evident here, and patient responded well. I think this was that the clinical challenges were reappearance of fever, but not related to underlying sarcoid, but due to the complication of macrophage activation. That's really a great challenge. Thank you.
Vidudha sir might want to put in his comments.
No, this will be conflict of interest, my case. So Professor Mishra will comment on it.
Actually, I'm devastated. I'm devastated. I've never seen a hepatic sarcoid being diagnosed without pulmonary involvement. Pulmonary involvement is the hallmark, and pulmonary eye. I'm not sure whether the eyes have been looked into some detail. Even I remember one sarcoid expert was saying, never diagnose a hepatic sarcoid unless the diagnosis comes outside the area of the gastrointestinal tract. So you need to have two distant places, and usually it is the lung, but it will be difficult to convince anyone that this is a hepatic sarcoid in absence of extrahepatic typical finding of sarcoid. Unfortunately, the skin biopsy or even the parotid gland FNAC, they were, you have to drag to make it a granuloma-like lesion. So that is, and I am just stuck in my mind that how can one make a diagnosis of hepatic sarcoid without the typical lung involvement? And the other thing was another brilliant, a lesson to be learned is the smoldering nature of macrophage activation syndrome. I always thought that it is a kind of explosive disease with a 15 to 25% mortality. I mean, Soumya intelligently explained that because he was taking low dose steroid or even mild to moderate, and therefore that could explain the macrophage activation syndrome of maybe 4 months or 5 months. That kind of steroid is never helpful for macrophage. If one cell is engulfing another cell, a dose of 15 milligrams steroid is not usually the case. I mean, we don't never treat macrophage activation syndrome with this kind of abnormality. So, and sarcoid causing mass would be a New England Journal case report. I mean, I am actually devastated by the rarity of rare cases being presented. I have to relearn something. I've never been taught to diagnose sarcoid based on only a granuloma in the liver, because as Kumudini said, there are 48 causes of which can cause granuloma in the liver, and very exhaustive list. And in fact, sarcoid, a granuloma in the liver, to make it sarcoid, you have to go through that horrible list. She presented, she told 3, and this patient also had history of some Ayurvedic drugs. So, thank you, Bidut, for enlightening me.
Of rare medicine.
Sir, can I ask a simple question? What would you have done if you had got a case like this? With the kind of restrictions that we have in our setup, how would you have managed this case? Unmute, sir. Unmute. Sir, unmute.
I would have managed the way you have managed, but not labeled that sarcoid. HLH is no problem. HLH is fitting in the criteria, so the treatment you gave is okay. It's just that the diagnosis of sarcoid is pinching me.
Sir, I think all the diagnosis today has been like that, has been a pinching experience.
Yeah. I never know that East Zone was known for rarity of rare problems.
Yeah, Kumudini. Yeah.
But very interesting cases.
Sir, actually, drug-induced liver injury is still in my mind. I can't explain why so much eosinophil is there. Also, I have found neutrophil. So that also I can get convinced that actually occasional eosinophil can be, but eosinophil was found in almost 40% of granuloma in that liver. I am stuck up with that eosinophil. So drug-induced liver injury is also in my mind.
Yeah.
That causes granuloma, steatosis, drug can cause. But the prednisolone doesn't cause granuloma. That Ayurvedic preparation, what it is contained.
He took Ayurvedic for 10 days. I mean, within 10
only
days.
For 10 days. Okay.
So the combination that we finally made is of sarcoid with NASH, non-alcoholic steatohepatosis, and maybe some evidence of drug. What about, do you think any parasitic infection can lead to, we have a lot of parasitic infections which can be eosinophilic?
But no parasites were seen in the biopsy, sir. The cystosoma.
No, in our condition, we don't see cystosoma in our place.
Yeah.
Histoplasma is common differential in this type of cholestasis. But
Histoplasma
no
was not
histoplasma
there.
available.
No, sir.
That's right. But as Dr. Misra was telling, it's very difficult to accommodate hepatic sarcoid in absence of pulmonary. That's the only concern. We may have to think for other differential as we are trying to discuss.
We sent this paper to hepatology. First, we sent it to Lancet, and hepatology said everything is fine, but I think we know such things happen. We have already discussed this before. I mean, they know this such combination can occur. That's the editor told us. When he returned, we asked him, what do you think is the problem with the case? He said, no, it's an excellent case. You've written well. But this kind of presentation our audience in Europe and America are aware of. So I was surprised. I didn't find a paper saying a sarcoid with HLH combination.
It is really an oddity. Yeah.
I think it's been a brilliant presentation.
Yeah.
But it's been quite, I mean, we're going off our timings also. So
yeah, it is actually almost 9:45 now. We have to finish somewhere.
Can I ask Pradeep to
comments? Yeah.
And we
Sorry.
learned a lot. We learned a lot, and a huge thanks to all the presenters. Can I ask Pradeep to sail off and wind up?
Yeah, I'll just actually this has been actually brilliant. One of the most actually exciting webinar I have attended, if not the most exciting actually. So, and we had close to 150 participants actually. So that's great.
That's an achievement.
So, and first of all, thanks to all the participants for sparing this Saturday night evening from 7 to almost 10 o'clock. So thanks to all of them. And thanks to especially Bidudas sir and all the AC members, because Bidudas sir told me that I have to make this meeting happening in December. So thanks to all the AC members and Bidudas sir for giving us this opportunity. And thanks to Olagendogo sir and Mr. sir, always has been like anything, Mr. sir. And Olagendogo sir has been always putting everyone at ease that don't worry, everything will be fine. And our presenters, Soima, Pradipta, then Sakir, and Dhrubajyoti, then Kamadini Madam, they have been brilliant all throughout this talk. And our moderators, they have run this whole thing flawlessly. So thanks to them. So and thanks to our IPCA guys for this. There was no glitch in the whole meeting. So thanks to them also. So with this, probably we can go.
Good night. Good night.
Thank you.
Thank you, everyone.
Thank you very much. Thank you.
Good night, everybody.
Good night.
Almost 10 o'clock. So thanks to all of them. And thanks to especially